your name and give it that pause and then go. You're good to start that.
Okay. Hi, I'm Martha McLeod. Okay. Good morning. We're pleased to be coming to you from the traditional territories of the Clydach in Prince George. My name's Martha McLeod, and I'm a professor in the School of Nursing at the University of Northern British Columbia. And my colleague is Peter Zimmer, and he can introduce himself.
And yes, I'm Peter Zimmer. I'm a retired Anglican priest living in Prince George, British Columbia. I've been here for 35 years, something like that.
Great. Okay. And what we're going to talk about today is what we learned through a self-study about how academic, patient, and public research team members work together on studies that focused on how research is done, that is, research on methods. I'd like to note the work and the contributions of the academic and patient and public researchers who work together and with us on this study and on the other studies. Several of them, as you can see, have joined the presentation, and their names are here on the slide. The 5 teams on the methods cluster, that is the knowledge translation and implementation science methods cluster, all studied very different approaches to patient-oriented research in knowledge translation and implementation science. From community-based approaches to citizen science, to consensus methods, to studying the use of media, to approaching implementation through different philosophical perspectives. We undertook the self-study to help us improve how our teams functioned, as there was very little research on teams studying patient-oriented research methods, that is, the methods of doing the research. And we wanted to know more about this kind of research and indeed how patient and public members could best be involved. Now, this slide outlines our methods. Essentially, we took a collaborative action research approach, held interviews with team members. We fed back what we learned from the teams to the teams, and then came to some final interpretations of what we learned after having special discussions with the patient and public research team members. And we learned that undertaking this kind of research meant several things. The first thing that we learned is that the methodological research, this approach to studying the methods, and is really about exploring approaches and processes. And in that way, it needs a tremendous amount of flexibility with the team because it works the processes, and so therefore is very vague in many different ways. Now, the second one is forming the research team. The match between team members and the work to be done is really important. The role of the research leaders in making good matches and building relationships among team members was key. It was not easy to achieve well-functioning research teams. As one person said, it was a bit of a dance to get it right. Now, teams needed to deal with the realities of COVID and other world events, which meant that team members needed to be attuned to language and equity and attend to them in the context of the team and the research methodologies with both sensitivity and kindness. So what did we learn? We learned that time and opportunities for reflections gave members new understandings and opened up ways of communicating in different and important ways. We found that most research team leaders adjusted their approaches throughout the process, and that was positive. And most importantly, we learned that patients and public members of teams needed to be heard and understood. Now, Peter's going to give you his perspective on being engaged in this kind of research.
The principles for patient engagement that we worked with were taken from the Strategy for Patient-Oriented Research published by the Canadian Institute of Health Research. This framework guided the construction and the process of the 2-year-plus study and self-study, and I believe they could serve as excellent guidelines for any patient-oriented research project. To that end, I'd like to share a few reflections on my experience. As Martha indicated, the engagement of patients and community members took place at a deep level. Initially, a great deal of time had to be set aside to build respect and understanding within the team. We came from several different communities, and Martha very wisely allowed for time and opportunity to get to know each other. As a research team member, I was involved in the planning, designing, and guidance of the project as it progressed. I believe that this involvement is integral to patient-oriented research. I came to understand that my relative ignorance of hermeneutics and implementation science was offset by other areas of expertise which I possessed. While I did not have the academic knowledge of others, I did know things experientially that my colleagues did not. I was able to bring the experience and knowledge gained through living with illness, as well as my experience with treatments and the healthcare system. Involvement of patients in research increases its quality, and as healthcare providers utilize research evidence in their practice, it increases the quality of care. And I discovered that my experience as a patient came to be valued as evidence. And lastly, the nature of my engagement evolved over time as I gained, we'll keep it on 8. Gained confidence and understanding in the nature and process of the study. The guiding principles were, SPOR recommends 4 principles which ought to guide patient engagement in research. These will improve the relevance of the research and improve its implementation, result in a strengthened Canadian healthcare system. Patient engagement in research integrates a diversity of patient perspectives, and research is reflective of their contribution. That is, patients bring their whole lives and worldviews into this. Support. Adequate support and flexibility are provided to patient participants to ensure that they can contribute fully to discussions and decisions. This implies creating safe environments that promote honest interactions, cultural competence, training, and education. Support also implies financial compensation for their involvement. Researchers, practitioners, and patients acknowledge and respect each other's expertise and experiential knowledge. And finally, patients, research, and practitioners work together from the beginning to identify problems and implement solutions. Both academic and patient researchers may need training in this. For the patient, this could involve the fundamental ideas of the research process. That research builds up knowledge that is based on data. That methodology is based on certain principles and theoretical assumptions. For the researchers, training in communication, which could cover everything from discussing methods and results to chairing meetings, is likely to be beneficial. Patient and academic researchers could even participate in training together, which helps build their relationship. What does success look like? Well, there are inclusive mechanisms and processes. Patient involvement at all levels means shared leadership, and decision-making process in which patients are co-building with academics, practitioners, and decision makers in collaborative research teams. I need to say that this is absolutely vital to the success of any POR project. Failure to engage patients at all levels dooms the project to dishonesty at best or failure at worst. Multi-way capacity building. There's support for creating safe environments that promote honest interactions, cultural sensitivity, training, and education. Every member of the team brings unique gifts to the table. When this happens, a safe environment of mutual respect is fostered and is characterized by honest conversations that inform and involve all the participants. Effective communication and collaboration. Next. Number 11.
That's one.
Okay. I apologize. A safe environment of mutual respect is fostered and characterized by honest conversations that inform and involve people. This needs constant attention throughout the process. Experiential knowledge valued as evidence. The experience of patients, families, and caregivers is mobilized and translated. When this happens, the quality of research is substantially enhanced. So, what are the takeaways? First, that KTIS studies evolve and necessarily focus on process. Flexibility, openness, and grounding in practical realities are needed. Everybody needs to bring their whole selves to the team. Power differentials and language need to be attended to throughout the project. It's important to understand the vulnerabilities of all the team members and respond with humility and kindness. And finally, while all this is challenging, when the above is addressed, patient involvement enhances KTIS methods research, and the resultant study is manifestly improved.
Great. So we really would like to invite questions and comments, and we understand that those questions and comments can be made at the end of all the presentations. So save those comments and we would love to answer any questions. So thank you very, very much.